So I'm going to be, this is Sue again, introducing the next couple of speakers, but did just want to echo Rafi's thanks for our two first speakers, both terrific presentations. And it's now my great pleasure to introduce Joe Eron, who is professor of medicine at the University of North Carolina Center for AIDS Research. He's the clinical core director, and he's also the principal investigator of the ACTG research unit. He's been part of the AIDS clinical trial group since 1993 and had multiple leadership positions since that time. He works with international sites in Malawi and in Vietnam. He has over 400 publications and has been active in the area of drug development and led or participated in original studies of many antiretroviral therapies. In fact, sometimes, I'm surprised when I see a new drug presented or published and Joe's name is not there as first or last author. He's incredibly hardworking and productive, and also on a personal note, I can say a delight to work with. He's very open-minded and inclusive, and I've just enjoyed my interactions with him over the years. I'm very much looking forward to his presentation on resistance in long-acting therapy for prevention and treatment, uncommon outcome, or Achilles heel. So Joe, I'm going to turn it over to you.
Great, Sue. That was such a generous introduction. It's always been a tremendous pleasure working with you. So everybody buckle up. There's been a lot of great stuff, but by Colleen and Adia, so I can really hit the high points here, and you can all see the slides. So off I go. I hope, please. There we go. Okay, these are my financial disclosures. These are our objectives of the actual meeting. So I'm going to talk first about confirmed virologic failure and resistance on treatment. So this is long-acting CAB and rilpivirine. So I think the first thing about understanding resistance, failure and resistance is to remember who enrolled in these studies. And Adia went over this, but I'm going to go because it's so important. So these are people that were on uninterrupted first or second oral therapy. Second mean they just changed therapies but stayed suppressed. There was no history of virologic failure, right? There could be no history of virologic failure, no known resistance mutations except a transmitted K103N. That's the only thing. They had to have a low RNA, of course, and then 2 additional RNAs less than 50 in the previous year. The exception to that, of course, was FLAIR that Adia talked about, who were treatment naive people, living with HIV treatment naive who were suppressed on oral therapy for 20 weeks. So keep that in your mind. So Adia talked briefly about this study. This is published just a little bit ago by Chloe Orkin and a really large group of people very experienced in resistance, looking at all the patients who enrolled in FLAIR, ATLAS, and ATLAS-2M that Adia's gone through. And she mentioned overall that 23 out of 1,651 patients had confirmed virologic failure. That's 1.4%. And that's about 0.5% per 100-person years, or 0.5% per year. The median time to failure was about half a year, 25 weeks. And the key point is when you have confirmed virologic failure, at least as it was defined in the studies, so 2 values over 200, the person was very likely to develop resistance. Most had resistance to both rilpivirine and integrase, and only 3 out of the 20 where they had genotyping had new mutations. So the numbers are small. I think Rafi's already said this. The numbers are small, but if you have confirmed virologic failure, then it's very likely that you'll get resistance. Adia showed this slide, and I just want to point out that once you get past this, here's a year on the slide, right? Once you get past a year, failure is uncommon, but it still happens. It's uncommon, but it still happens. So what are the predictors? And this is really what Chloe Orkin and the group really looked at. So what are the predictors? It was a very sophisticated model. It took me almost 2 hours to read the paper, but I'm going to give you the bottom line. There are 3 things that showed up. One is if you had rilpivirine RAMs at baseline, you had a very high likelihood of resistance. And you might say, well, but these people shouldn't have failed. How do they know they had rilpivirine RAMs? They looked at either in FLAIR, they could look at the baseline genotype because those were treatment naive people. But for most people, they looked at the DNA archive. If you had this crazy, unusual, at least in the US, subtype A1, A6, then that also had an increased risk. And people with a BMI above 30 were at a slight elevation of risk. So look at the relative risk was quite small, 1.09. And on the right, if you just look at, if you had no baseline resistance factors, 4 out of 1,000 or 4 out, so that's obviously about 0.4%. If you had only one, it was higher, right? It was about almost the 1.4% that we saw overall. And I just want to point out, if it was your only risk factor was BMI, it was 1 out of 200. So again, that's about 0.5%. It's almost the same as with no risk factor. And then only 31 people had a rilpivirine RAM at baseline, only 31. So 1 out of 31. So that's how those numbers shake out. So what about in the most recent study? This is SOLAR. These were people that had to be on uninterrupted BF-TAF, and they could only have been treated with an integrase. So no virologic failure, were treated with an integrase, were on BF-TAF. So they no history of a non-integrase regimen. And again, you see this remarkable success that Adia talked about, but 2, again, 0.4%. This is a year-long study, so 0.4%. 2 did develop confirmed virologic failure, and both had resistance mutations. Both had resistance mutation. So it's uncommon. It's not like oral therapy, which I would call rare or very rare or case report level, but it does happen. And it happens even in very well-controlled studies where people get their medication on time. So again, Adia looked at this study. This is the OPERA cohort, people suppressed on therapy. Most were suppressed, and they switched to oral. They switched to cabotegravir rilpivirine. So this is looking at the people who were suppressed, less than 50. And I'll just go right to the bottom line, 1%. 1%. So 16 out of almost 1,500 people, almost 1,600 people, so almost exactly 1% had confirmed virologic failure. I want to point out 2 things about this particular presentation. One, the median follow-up was 7.4 months, and less than 25% had 1-year follow-up, so very short follow-up for the majority of people. And the other thing is there were no resistance data. So no resistance data from this particular group as yet. I'm sure they have it. I'm sure they'll share it with us. And Adia also mentioned multiple studies at the EECS meeting. That was in Warsaw. So there was a French study, again, 1,100 people. They had a very strict definition of virologic failure, but they had 8 virologic failures with discontinuation, and they actually had 4 that had resistance. And again, those 4 out of 8 had resistance and resistance to both agents. And then Anna-Marie Wenzig described 5 virologic failures with resistance. Again, no denominator here, so hard to interpret. But these are all people that had on-time injections. but curiously had lower drug concentrations than anticipated. So virologic failure happens. I think of virologic failure almost synonymous with resistance emergence. And as Rafi, Adia have already said, it can happen even when it's on time. And then I know there was a lot of discussion already about this cohort. This is Monica Gandhi's cohort from San Francisco. And she had a percentage of her patients, about 30, almost 40%, that were viremic. And most achieved virologic suppression. But I do want to point out 2 out of 57. 2 out of 57. Remember, in people who are suppressed in the ViiV studies, it was 4 out of almost 1,000. This is 2 out of 57. And again, they developed either this person developed non-nuke resistance, and this person developed substantial integrase resistance. And T97A, that's a polymorphism. It's not a precursor to resistance. That's been studied very extensively. It does lead to resistance to L-bictegravir, but it did not kind of soften this person up for resistance. So treating people with viremia, the risk of resistance, I think almost by definition, is going to be higher. So here's our case. This is a man diagnosed 20 years ago, and you are seeing him new. You have records for the last 10 years. He's been on integrase resistance. He's been below detectable. He's currently on BF-TAF and suppressed. He recalls that he was on efavirenz TDF-FTC, which we used all the time, but he stopped. And that was 20 years ago when he began. And he didn't take therapy for a while. And he believes that he has been suppressed since going back on therapy. And he's not aware of any resistance testing. So what is your next step after failing to get additional old records? He's a traveler. He wants oral therapy. He wants long-acting therapy. He's asked for long-acting therapy. So what would you advise? Would you advise against long-acting therapy? Would you start long-acting therapy with a 2-inch needle? His BMI is 35. Would you start long-acting on the recommended schedule for 1 monthly? Would you get a DNA archive, look for rilpivirine resistance mutations, or you're not sure? So go ahead and vote. There's no right answer here, but let me see what you think. Okay, what do people think? So some people advise against. Wow, this is really interesting. So 2/3 of people would get an archive resistance test. I think that's a very reasonable strategy. And I think if I found resistance on an archive, I would not go forward. If I didn't, I would probably go forward, but I would really go forward very cautiously and say, I know you travel a lot, but you're going to have to come in and we're going to have to watch you carefully. And I'm going to get a viral load with each time you get an injection for the first 6 months or so. And I would still use 2 monthly. The failure rate's a little bit higher with 2 monthly, but again, I think given what he's asking for, that's what he wants. And Adia talked about patient-centered therapy several times, so I think that makes sense. If this person had a BMI less than 30, if this person had only been on BF-TAF, his likelihood of resistance would be less than 1% over a 2-year period, 2 to 3 year period, based on the data that I showed you, And when I say resistance, when I use the word rare, I mean very rare. So it would be less than 1%, but not 0. That's the thing, not 0. Okay. Oh, I got to click on the slide so that it goes forward. All right. So what are the risks for resistance? Well, there's subtype A1. We talked about that. If someone had the A1, A6 genotype, I would and there were oral therapy, or they were doing this mainly for convenience issues, I would avoid CAB rilpivirine. If they have known rilpivirine mutations, if they have oral treatment options, once again, I would avoid CAB rilpivirine. I think this is really the highest risk of resistance, and I know you've had discussions about treating viremic people. If someone has suspected virologic failure on an NNRTI, again, if there are no treatment options, I would again be anxious about using this. And I think an archive genotype is one way to look at this. If there are no documented resistance mutations, again, I would just caution the patient about increased risk. For me, the issue of people who are viremic, I don't think there's enough data to understand the risk of resistance. Certainly, you would genotype the person prior to treatment because you have viremia. That's a good test. And I personally agree with Paul Sachs on this. I would only use this if someone couldn't succeed on oral therapy and is at a high risk of disease progression. BMI greater than 30, if that's the only risk, I would not have concerns. Rafi asked me, why is A1, A6 a risk? The only thing I'm going to say is it turns out that if you have person infected with A1, A6, then the virus actually, because it has this L74I, it actually becomes more fit when it acquires resistance mutations. On the other hand, if you have subtype B and you don't have L74I, you have then you have the virus actually becomes less fit if you put L74I into a subtype B. So it's all about fitness. So what do you do if there's virologic failure? If there's a long gap between injection and rebound, obviously you get resistance testing. If there's no resistance, I would be fine with an integrase plus a tenofovir FTC. If there's no resistance and no gap, I would be very careful, but I would start integrase plus tenofovir FTC. But I would get a resistance test on the day I started in case there was an increase in viral load, and I would get another one 4 weeks later. If there's NNRTI resistance and no gap, again, perhaps an integrase would be appropriate there. But I think that if you're unsure about resistance, or if there is resistance, I think that the concern there is it's most likely that the person would be successful on a boosted PI. And I think failing this regimen, it's most likely that the best regimen, if you have dual resistance, is going to be a boosted PI, which has risk to the person over time. So what about resistance during PrEP? You've seen these data already from Colleen, a fantastic result with long-acting PrEP. And I just want to really highlight this. There were 2,244 men or transgender women in 083, and only 25 infections. This is with the primary. There actually is a follow-up study was just published by Rafi, where they actually go into the unblinded period, but there were 25 and only 10 out of 2,244 at the time this was published developed integrase resistance. You've heard about these various categories. I'm not going to talk about them specifically, only to say that the ones that we worry about in terms of selecting for resistance, and Colleen's talked about that, if there was no CAB administration for 6 months, very unlikely in the studies to develop resistance. So far, no one has in this tail phase. But it's these other times, oral therapy, or if they're infected at baseline, that there is a risk of resistance. Here are the resistance emergence that Mark Marzinski presented or published just earlier this year. And again, I'm going to ignore L74I. But what you can see is that there can be substantial resistance, and almost all these would be resistant to dolutegravir, maybe with the exception of N155H mutation. So again, when you have rebound, when you have infection in the presence of cabotegravir, there clearly is a risk of resistance. These are kind of the various types of case. So D6, this is someone on time injections up on the upper left corner. And when this happens, you see resistance. B2, this is an example of someone who has this very long period between their last injection, which is the green stripe, and they had a high viral load when they were infected, and wild type virus, and they went on to TDF, 3TC, and efavirenz. This is someone who had a delay in their injection, but did become infected. This is here's at the time of the injection. And again, they did develop a mixture, probably resistance here. And again, this is a person, unfortunately, who had a long delay, but then they restarted at the time they were positive. So again, there's no RNA here. They restarted at the time they were positive, and unfortunately, they developed a resistance mutation. So resistance happens, but it is uncommon. Now, what about women? You probably know, and I didn't hear all of Colleen's presentation because I was getting ready to Zoom with you guys. But cisgender women, one thing we know is that women tend to have a greater exposure and longer duration when given the same cabotegravir dose as men. So this is HVTN. It's HPTN 084, not HVTN. Mike Cohen will be really upset with me on this slide. HPTN 084. So cisgender women. The overall result was 40 infections with almost 4,000 woman years. And there were only, at the primary result, there were only 4 infections. So 4 infections on cabotegravir with almost 2,000 person years. And obviously that was highly statistically significantly better than with oral TDF FTC. Overall, with the blinded and unblinded period, there were a total of 6 infections. And I think this, whoops, I'm sorry, one of my slides is missing, but there were no infections with on-time injections in women. And to date, there haven't been any presentations of cabotegravir resistance in women on 084. And again, here are the examples of the infections on cabotegravir. This is a woman who was infected at baseline. In the B1 and B2, these were women that were infected kind of after their oral therapy. This was a woman who was affected right at the start of her oral therapy. And this woman was infected literally a very long time after and had never really gotten an injection. This person was infected after oral therapy, but her adherence was 0%, so C1. And then there was one woman infected after a period with no injections, and she was discovered to be infected at the time of injection. So none of these women were actually getting on-time injections, and to date, none developed resistance. So no infections with on-time injections, and no infections presented to date with acquisition of resistance. So this is a 23-year-old cisgender woman who's receiving CAB-LA for PrEP. She did not take the oral lead-in, and occasionally is 7 to 10 days late. However, she's not missed any injections. She does exchange sex for shelter and food. Her partners do not wear condoms. And at the time of her most recent injection, you don't have a viral load yet, but her antigen antibody test is positive. And a viral load was ordered, but not done. So what's your next step? Do you begin antiretroviral therapy right away? Begin antiretroviral therapy, but obtain HIV RNA. Ask the client to return to clinic, redraw a antigen antibody test and hold the ART. Ask the client to return to clinic and obtain a antigen antibody test and an RNA and hold the ART, or you're not sure. I think D is what Colleen said. She would do every test available. But what would you do? So go ahead and vote. And we could see those results, I think. Yeah, so it's interesting. A lot of people, again, interesting, two-thirds of people would begin antiretroviral therapy, but obtain an RNA. So I'm going to talk through this, but I think you're going to be surprised to learn that the likelihood that this is a false positive test is incredibly high, at least in the context of 084, because this is a cisgender woman with on-time injections. The likelihood of her infection is very low. So let me walk you through that. Oh, I gotta click on the slide. So this was a study presented by Meena Hasinipour at Brisbane in Australia this summer. So they wanted to objectively define what the predictive value positive of a test was in the context of 084. So there were 3,224 participants, and of those, 159 had a positive reactive test. Now remember, these women were not getting RNA in the randomized part of the study, and of those 159, 88 were false positive reactive tests, and 74 were true positive. 8 on cabotegravir, but most of the true positives obviously were on TDF-FTC. And just if you look at this, the antigen antibody test, again, this is on cabotegravir. 7 were positive, 42 of the total positive, only 7 were confirmed. So that comes back to a predictive value positive of 17%. And then any rapid test or antigen antibody test, 55 were positive, but only 8 were actually confirmed infection. So that the predictive value positive of an antibody test was only 50%. If you had 2 tests that were positive, then the predictive value was much, much higher. 2 reactive antibody tests was 100% the predictive value, but it was only 4 out of 4 because there were so few with cabotegravir. So if it were me, and I would have the woman come back, I would do what Colleen said, get an antibody test, a viral load, get a really good history, but I would probably wait to start oral therapy until the RNA test was back. Okay. All right, so this is a similar case. This is the 23-year-old cisgender woman who's receiving CAB-LA for PrEP. She is well-documented case of HIV infection, so this woman has infection. She received on-time injections, but her viral load returned at 150, and repeat HIV RNA was positive. She did not start ART because you didn't have those tests back, and she returns to clinic. So what would you do? Repeat RNA and get a genotype and start BF-TAF. Repeat RNA, get a genotype and start dolutegravir twice a day with tenofovir and FTC. Repeat RNA and genotype, start efavirenz or doravirine-based therapy. Repeat and start a boosted PI. Repeat and wait for the results. Something else, or you're not sure. Again, no right answer here. Okay. So the majority of people would repeat RNA and start a boosted PI. Certainly that is not wrong. Remember, this person is very likely, well, almost certainly to have only integrase resistance. So if you're starting therapy, a boosted PI would be fine, or efavirenz plus doravirine would be fine. But the bottom line is we don't really know. What we do know, and this is from work by Sue Eshelman and Mark Marzinski, we do know that if you get an RNA really early, you may avoid selecting for integrase resistance. And this is the bottom line of that diagram. When they did testing based on the protocol, 6 out of 6 had major integrase RAMs. My time is up. But if you actually went back to the earliest possible viral load where the with a sensitive assay, only 1 out of 5 did. So it's possible that if you're catching people real early, they don't have integrase resistance. The problem with a viral load of 150 is you may not be able to get a genotype. And I think in that setting, either boosted PI or NNRTI based therapy might be reasonable. But I'd love to hear what other people think. Here's my summary. So in people suppressed on ART, switching to CAB-LA, virologic failure is uncommon. It is less than 1% without resistance, without risk factors, or just an elevated BMI alone, so less than 1%. However, if you have failure, dual resistance is possible. And we talked about the risks such as subtype, pre-existing rilpivirine resistance, and likely CAS failure on an NNRTI. In phase 3 studies of CAB-LA for PrEP, failure is rare, quite rare, well less than 1%, especially in cisgender women. But integrase resistance is likely for infections identified around the time of injection. Those identified later on the tail, much less likely and not documented in the studies. And antiretroviral options exist, but the optimal strategy there is uncertain. So here are some references to look at, and I am done.
Joe, that was terrific. And so we do have some questions for you in the chat. We were scheduled to end, I think, in about 5 minutes, but we can go a little bit longer than that and cut into the break by a few minutes because I would like to get these questions answered. So I wanted to turn my video on, Tom, but I can't. So I would like to start by asking you a couple of sort of related questions about your own practice or what you recommend. Should we get proviral DNA for everyone prior to switching to long-acting cabotegravir and rilpivirine? And as a follow-up, if you see any NNRTI mutations, would you avoid it, even if it's just a K103N? So should
great. Yeah, great questions. So I would say absolutely no, I wouldn't. I mean, in people who when they started therapy and they've been suppressed, I don't think there's any reason to get archive genotype. I think you're totally fine there. If they have baseline resistance testing, that's helpful. That's where you find out what subtype is. Any standard resistance test that's a genotype will tell you the subtype. A phenotype won't necessarily tell you a subtype. In the question about 103N, if that is the only mutation a person has, presumably transmitted, I think rilpivirine is fine. I know that people have talked about, there are lots of, for people that want these injections, there's so many benefits to being on this therapy in terms of stigma, in terms of their person's mental health, in terms of how people feel about themselves. So I'm not minimizing this. I do think that if the history is really foggy and your clinic can afford it, or your office, I think archived resistance test is reasonable. Just as Adia said earlier, it's reasonable. But if someone has a history of NNRTI failure, I would only do it if they say, I just can't take oral therapy any longer. That would be the only reason.
Yeah, I completely agree. And then just a question about what tests show this subtype. Some resistance testing, especially if you have sort of a homegrown one that your local lab does, may not actually report this. And so I think it's important to look and make sure that you're getting it, and if necessary, change the vendor for that.
Absolutely. Yeah, 100%. They probably know, but they're not reporting.
Right.
Absolutely. Good point.
Exactly. Yeah, exactly. And then what about therapeutic drug monitoring after initiating therapy? I'm assuming
Yeah, yeah, that's a really good question. I don't know the answer to it. I think my supposition about people who fail on-time injections, and the Europeans do a lot more therapeutic drug monitoring. They show low levels of either rilpivirine or CAB. I think it's injection failure, and I really think that really making sure the people doing the injections are really experienced, really pay attention to that. I think that's critical. I don't know that it will really help. I don't think the parameters are that good. And I also think that, you really have to have a validated test for both rilpivirine and cabotegravir. So I certainly don't recommend it, but so I don't think it'll be that helpful.
Yeah, I completely agree. And if you look at the Atlas and Flare data, the PK data from that, people that failed were within the range of
Absolutely.
everyone else's drug concentrations, and maybe a bit towards the lower end. And so if you do a test and then you get something that's a bit low, what are you going to do except worry about it? But I completely agree with you, making sure that people doing the injections really doing it properly, because there is a technique that you need to learn.
And with it higher than obese BMI, I definitely use the 2-inch needle. There's no question in my mind that is critically important.
And then what about, would you put someone with a high BMI on a monthly schedule? I'm not sure why not, but maybe you could just answer that.
Yeah, I don't think it's necessary personally. I think it's fine to go with the 2 doses a month apart and then the 2 monthly schedule. I don't think you're saving anything really.
Yeah, and then I'm just going to ask you one question, and then I think that's all the ones we have in the Q&A. So when you have a patient in front of you who's doing pretty well on oral therapy and they want to go on these injections, they've read about it, they've heard about it, Lord knows it's like advertised on the television even, and they've been undetectable, they're probably a suitable candidate. What do you tell them about what are the considerations they need to think about for doing this, and do you tell them about what might happen if it fails? Because as we both know, rarely, but it can fail in people to do everything exactly right, and then their virus load pops up and there we are. So what do you tell them?
Yeah, I try to be as honest as possible. I worry about what people hear. I tell them that on oral therapy, your success on oral therapy, the likelihood that you are going to fail with resistance is as close to 0 as we can get. But what will happen on injectable therapy, even if you're on time, there's around 0.5%, so a 1 out of 100 chance over a couple years that you could fail with resistance. And I'm not sure people hear that. I'm just not sure they hear it, to be honest. And I do think there's a lot of benefit to being on injectable therapy for the right person. And if someone really wants it, I think, again, it's kind of very patient-centered is what we're trying to do. But I don't know. I do worry that people aren't hearing when I say there's still a chance of resistance.
Yeah. Yeah.
And if, yeah.
You tell them that if there is, then you're going to end up on a boosted PI for the rest of your life?
You know, that's a really good question. I haven't said that specifically, but that you could say that. I mean, there may eventually be other alternatives. It's possible that they would be one of the lucky ones that doesn't have resistance, but yeah, you could say that too. That's a good point.
Yeah, I thought it was interesting in our audience response, the number of people that picked a boosted PI as the kind of go-to regimen, and I think it reflects how comfortable we all are with that being more or less a bulletproof regimen when things go wrong. But
yes, yeah, but it has, as you say, there are consequences to boosted PI, no question.
There are. Okay, I think we can adjourn now. Thank you for a terrific presentation. We now have a break that will end at 1:30 Eastern time. So those of you not in Eastern time can work this out, or just know that it's about 15 minutes from now. So please be back on time at 1:30. Thank you.